Thank you, Dr. Abdullah and the organizers. It's an absolute delight to be part of this cardiology race. So my mission today is to tell you that metformin is not number one. I'll start with few cartoons, timeline, because when it's a journey, so I need to start with telling you that metformin is as old as insulin, because it was discovered early on with insulin era. Even though it didn't go into US till 1995, but was discovered as a herbal treatment, Gallica plant, supposed to be guanidine in it, so that has reduced glucose at that time. But my mission, I'll just say it up front because of time, is really to convince you and convince myself, because up till yesterday clinic, the patient is always asking about HbA1c, tarakomi. That's not the case anymore. We need to change now, and I'll tell you why. Okay, so the past, the present, and the future. We're just going to tell you that movement from metformin to SGLT2 inhibitors, I'm going to stop there because rushing and preparing this talk actually overstepped and went into GLP-1 receptor agonist. So I'm going to fast forward when I arrive to that. It has passed through many years. There is a gap happened in the middle where after sulfonylurea second generation, there is nothing. And then there is a flux of medication, mainly after cardiovascular outcome trials. That's SGLT2 inhibitors and GLP-1 receptor agonist. And GLP-1 receptor agonist made a major difference because of obesity and the fact that we need to address diabetes as a cardiovascular disease and not as a glycemic disease, glucose disease. Having said this, and this is, I'm sure this is common everywhere, particularly in this region here, we're seeing type 2 diabetes at a younger age. I included this cartoon slide because we're seeing people at 30s and 35s, and this is mainly, we shouldn't forget that there is monogenic diabetes, and we need to look for it. Robert Tettersall and others made a major difference in discovering the monogenic forms of diabetes. And that's when you really need to try tablets and not to start every young patient with diabetes on insulin. We have to be careful with that. So the journey I'm going to tell you about is the game-changing drug industry when it comes to anti-diabetes medication. We used to just target the glucose reduction. But what happened after 2008, Steven Nissen, and if I remind you with not troglitazone, TZDs, but rosiglitazone story. And that's when there is mortality was high in the intensive arm of glucose control. And after that, the FDA asked for safety, at least neutral, but safe. It would be better if there is a reduction. Remember, 1.8 confidence interval. And after approval of medication, you need to do another study where the confidence interval has to be, the upper bound is 1.3. So you see medication in the market, but another study going on, a cardiovascular outcome trial going on to prove the second metric. So diabetes, cardiovascular outcome trials, and evolution of internet. So the evidence, the body of evidence, both in across the Atlantic, confirmed that we need to go for certain medication. We can't just go for HbA1c. And the best two players in the game to address the 3-point and 4-point MACE and hospitalization of heart failure was basically SGLT2 inhibitors, the Emberg, if you remember, and the DABA heart failure and DABA CKD. As I said, I'm not going to step on the GLP-1 receptor agonist trials. Medication, I don't think this is one of the objectives of this talk, but I mean, metformin, for instance, used to be mainly for overweight and obese patients, A1C more than 6.5, but not necessarily because we use it in pre-diabetes as well. Problem with tolerance as well, so really need to advise your patients to take it after food or within the meal. So usually better always to start, because nowadays we're doing diabetes management as we're supposed to be doing hyperlipidemia and hypertension. We don't start with single medication anymore. But what's common now is to go for 1,000. That's not the case because of tolerance. Better start low and go slow. This is the Gallica plant. So patients already on metformin, you don't need to stop that, but you wouldn't start it if estimated GFR less than 30. DPP-4 inhibitors is in the journey as well. They're more tolerable, but the effect is not as good as the most recent medication, i.e. SGLT2 inhibitors and GLP-1 receptor agonists. Water-related, but as I said, you need to start combination treatment. The journey goes on, sulfonylureas, but particularly in UK, if there is hypos, you need to inform the DVLA. You have to be careful in case of renal and liver failure. Again, you start low and go slow. Right, I'm supposed to be stopping at this station here, the SGLT2 inhibitor. The summary of that they are highly selective SGLT2 inhibitors, and the action is insulin independent, so it won't lower blood sugar like sulfonylureas. Most of them, if you remember TCOS and other studies, are cardiovascular outcome, cardiovascular risk neutral, unlike the other medications. SGLT2 inhibitors, you have to be careful with somebody using loop diuretics. Somebody volume depleted as well. Blood pressure, you have to watch it. And you have to reduce the dose of insulin and sulfonylurea when you use it. Sometimes you need to ask about UTI infections and genitourinary infections. Why not glitazone? Glitazone is a good brand medication, can be used. However, two medication has gone down through glitazone because of toxic effect and rosiglitazone because of mortality. So the only one we're using now is biglitazone. And the effect through PPAR gamma, remind you, and the effect as you can see in the slide. By the way, I think I understand from organizers, because of time, I just want to tell you that will be PDF on the website of this conference. So slides can be seen at a later date. TZDs, slow onset, but the effect is usually good. Again, the only option we have is biglitazone. Have to remember that there is some adverse effects like fluid retention. Biglitazone, sometimes you need to ask about macular edema, things like that. I fast forward this for Dr. Bara. So, ladies and gentlemen, the change now in management that we don't go for HbA1c. This is from ADA standard of care. We go for glycemic control, blood pressure, lipid, and it will be multifaceted treatment after lifestyle modification. And same applies for the consensus of ADA and ESD. Management has to be multifaceted, in the way that we do glycemic management, cardiovascular risk factor, and cardiorenal as to stratify and address the weight. Obesity is major factor in diabetes control. This is just leave you with this algorithm 2023. This is Manchester Council or Manchester Hall. Thank you. I can just say one thing. I think in a busy clinic, you can sometimes address cardiovascular factors, and this is the basis of my master research in the University of Liverpool. We employ the research nurse, and that's in the year 2000, 2003, before moving to this country. We had a specialist nurse, cardiovascular specialist nurse, and she has to address the cardiovascular risk factors. And we proved that blood pressure, total cholesterol, and all risk factors has been reduced. I think in a busy clinic, sometimes you cannot address but the HbA1c. But I don't know how applicable is this nowadays to have a diabetes educator and cardiovascular specialist nurse, maybe not in the private anyway.